No, that's fine. As Trish said, I'm kind of representing the BBJ HIT. The co-directors are Sarah Hewlett, who leads the self-management and rheumatoid arthritis theme, Emma Clark, osteoporosis and fragility fractures, and Ashley Blom, surgery for osteoarthritis. And my particular interest is in osteoarthritis and self-management, so kind of brings together a couple of those things. I'm actually a physiotherapist and researcher at UWE. And actually the focus we're going to have today for our HIT is just taking one intervention that we've developed and looked to roll out locally and nationally. So Escape Pain is an integrated exercise and self-management for people with osteoarthritis. The good news for us as researchers is that 8.75 million people in the UK have osteoarthritis, and the numbers are significantly growing as our population gets older, heavier and generally less active, all of those things that contribute to the development of osteoarthritis. So what is Escape? Well, it's a 10 to 12 session group exercise program that integrates exercise and a self-management intervention. So half of that time of each hour is spent on self-management skill development, and the other half is spent on exercise. The theoretical basis for the intervention is to build on people's motivation, so self-determination theory, and their self-efficacy as well, so social cognitive theory. The intervention is facilitated by a physiotherapist, and it's critically based away from secondary care, so in primary care and community settings, because that actually helps to kind of facilitate that self-management approach and that transition of self-management out into the community. So what is the evidence for Escape? Well, it was initially based on an RCT, so of 422 people. And the results of that showed that this very brief intervention increased clinical and cost effectiveness 2.5 years post-intervention compared to GP care, whatever GP care kind of consisted of. Clinically, that meant people's pain was reduced, their function improved, and their quality of life improved. Importantly, what it meant from a cost point of view was that it was cheaper and more cost effective to manage people on the intervention compared to GP care. What we also did is conduct a further small RCT that compared our Escape intervention to standard physiotherapy, whatever that might be. And over a 1-year period post-intervention, the treatment costs of Escape versus any other physiotherapy, we saved £66 per patient coming through, and the healthcare utilisation costs over that 1-year period were £263 reduction per patient. Kind of the grander scheme of things, actually that's a relatively small saving, but actually when we think about the numbers of people coming through the door, so musculoskeletal problems are the key issue for people coming into GP practices, and certainly obviously in physiotherapy as well. So that is a considerable saving that we can achieve by implementing this intervention. So what do we do to assist implementation? We all know an RCT doesn't cause something to be implemented. It's sort of those other things that kind of go alongside that as well. So we got a QIP approval, which is quality, innovation, prevention and productivity. Yeah, please, I got it wrong this morning as well. So this is a case study document that looks at the evidence for an intervention, how quickly it is to implement, any training needs, the payback, how quickly the payback might be achieved. And actually we got QIP approval for this intervention. So this is now flagged up to commissioners that this is maybe something that you want to consider for kind of cost savings. We also developed a website, so all of our materials to deliver the intervention are freely available on the website, including all of the kind of presentation materials, the outcome measures that we're allowed to use, testimonials on there from patients as well, just to kind of validate, I guess, some of that intervention. And we do provide the option for people using it, if they want to submit their outcome data to us, obviously anonymised, we're happy to take that and collect that and have kind of this big data set that we can look at in the longer term. Our work also was included in the NICE osteoarthritis guidelines a couple of years ago. So again, that helps to start to raise the profile. And I'll show you in a second, but we started this work. So I'm kind of from London, as I've moved up here from London. So we started this work in London and around the southeast. And it's been adopted by the AHSN, which is the Health Innovation Network in South London. And just very recently, the West of England AHSN have also kind of come on board and are helping us with the rollout of this. Last year, we received a Royal Society of Public Health and Wellbeing Award for the intervention. And this year, a British Society of Rheumatology Best Practice Award as well. So it's these things that kind of help to raise the profile and help with the implementation more than kind of the RCT that we have up front. So where's it been implemented? Well, kind of, as you can see from this, that the biggest success so far is where we actually started the intervention in kind of the first place. So we have early buy-in, because those people kind of see the benefit very early on. So I'm really happy to kind of buy into that intervention. There's a little flag over in Bristol here, as I'm kind of here now, so can do my bit to try to sort of promote it locally. But equally, what we do have are other areas now that are starting to come to us to say, look, we're really interested in this approach. You know, our professional body, the Chartered Society of Physio, really helping us to kind of plug it to. And as Selina pointed out earlier, a little flag here in the Republic of Ireland as well. So our internationalisation going on here. So what now? Well, had a chat with Anna Burhouse at the AHSN yesterday, and we've secured £5,000 from the West of England AHSN to assist us with kind of further rollout locally, and also access to their Pfizer management fellow that sits with the AHSN at the minute to kind of project manage it. And Anna did make us aware that actually there's another potential pot of up to about 75,000 for projects of looking at the rollout of this model. And actually what we're really interested in is thinking about how we can use exercise instructors to facilitate this model. And if we can actually deliver it in an even more cost-effective way, and actually an even more appropriate way by basing something out in the community. And what we're kind of thinking of is voucher schemes available through primary care that you then go out into leisure centres to access the escape programme. We've also got some employers in South London who actually have adopted the programme and are providing it for their employees. So obviously to help to try to keep people in work as well, improve productivity. And further along our kind of internationalisation route, we're also working with the health service in Hong Kong, as the ethos of self-management out there is something that's kind of really slowly developing, because culturally it's not something that's come to the fore in their kind of healthcare system. So we've got an intervention that we know works in our kind of Western European environment, but actually it's thinking about how we can take that package over to there as well. So that's kind of where we're at with sort of a local intervention and how we've kind of got on to really try to roll that out there. Sorry, just to also, I forgot this earlier, just to say that this work was originally funded by Arthritis Research UK, and they funded me as well. And the AHSN in South London is the Health Innovation Network. So, you know, they worked incredibly hard, obviously, in rolling out this intervention too. Thank you.
That's great. Thank you very much, Nicola.